Okay, hi guys, welcome back to the video for this month. This time we'll be soon ending with the updates in the myeloid also. So hematolymphoid updates will be covered and over hopefully in another month. And because I'm not able to upload frequently or it would have been over sooner, then again we can start with some histopathology topic. And maybe then after that we are going to start with some benign lesions of both hematology as well as histopath topics. So now today the topic from that update paper, the book is yet not available, I think. If it is, then do comment. Otherwise, from that update paper is the secondary myeloid neoplasms. You know that both lymphoid and myeloid neoplasms have gone through changes. So coming to the word secondary myeloid neoplasms is actually AML, which was drug induced, or the dysbiosis, which was drug induced. The therapy induced acute myeloid leukemias or myeloid neoplasms have been called the secondary myeloid neoplasms now. Fine. So this is a newly segregated category encompassing diseases that arise in setting of certain known predisposing factors like post chemotherapy. Secondary to exposure, see here over here, cytotoxic therapy or germline mutation. Fine. So they have clubbed AML with germline mutation or post therapy AMLs into this category. They will club. AML transformation of MPN, when an MPN gets like a CML converting to acute leukemia, has been retained in MPN itself. So when they say known predisposing factors, so if a CML goes into blast crisis, then that kind of leukemic picture will not come into this. What will come into this is if someone had some sort of disease before, some cancer or both lymphoid, hematological, non-hematological, or has some sort of mutation, germline mutation, which can cause a cancer. That kind of tumor will be categorized into this category. AML with KMT2A rearrangement post cytotoxic therapy, or MDS with low blasts associated with a germline mutation like RUNX1. These entities where there is a known mutation but there is a history of a predisposing factor also, where will you put this? If you know that there's KMT2A mutation and you also know that there is post cytotoxic therapy, where will you put it into TML or will you put it into germline? So they have created a separate category for this. So myeloid neoplasms post cytotoxic therapy, introduction of a more precise terminology and novel associations with new cytotoxic drugs. So what comes under this? Diagnosis of myeloid neoplasms post cytotoxic therapy, that is MNPCT. This is the terminology used, entails fulfillment of criteria for a myeloid neoplasm in addition to a documented history of chemo. Case with a de novo molecular signature such as NPM1 mutation, core binding factor leukemia should still be assigned to this category since the post cytotoxic therapy designation is based on the medical history. CCUS will, however, be excluded. Alright. PARP1 inhibitor added as a qualifying criteria for MNPCT and methotrexate has been. So, CCUS and methotrexate therapy ke baad, if you are developing something, then do not label it into this category. But otherwise, if any other post chemotherapy with a germline mutation history is available, then please put it in this category rather than getting confused ki germline mutation mein dalna hai, yeah, you have to put it in post therapy. Outcomes of such patients, of course, expected is poor. Worse with biallelic hit, that is TP53 mutation, manifests with greater than 2 TP53 mutations or with concomitant 17p p53 deletion or copy neutral loss of heterozygote. Now these terms are jargons which you will have to understand after you study the carcinogenesis chapter from Robbins. Loss of heterozygosity means the nature that there are the heterogeneous nature of the chromosome that gets altered. The phenotypic heterogeneous presentation gets altered, and then you get a tumor. Less frequent mutations involve genes such as PPM1D, DNA damage response, genes that may require additional workup. Fine. So this is a bigger spectrum, but to remember P53 mutation. All right. So this chart is given online also. So AML with minimal differentiation is now blasts are negative less than 3% for MPO and SBB. AML with maturation greater than 3% blast, monocytic lineage constitutes less than 25%. So all those designations that you had for different classes of AML are changing. For instance, AML M7 is that is megakaryoblast leukemia is blasts express at least one or more of the platelet glycoproteins, that is CD41, CD61 or CD42B. Acute erythroid leukemia, you remember 6A6B, greater than, now it is greater than 30% immature erythroid cell, that is proerythroblast. Bone marrow with erythroid predominance, usually with a greater than 80% cell, that is no 6A6B. Acute monocytic leukemias 5A, 5B, 5C? No. Greater than 80% monocyte and or their precursors, that is monoblast, promonocytes. Blasts and promonocytes are then less than 20% maturing granulocytes, and blasts and promonocytes express at least two monocytic markers, 11C, 14, 36, 64 and NSC. Myelomonocytic, greater than 20% monocytes with precursors, 20% maturing granulocytes, and greater than 3% blasts positive for NPO. Basophilic leukemia, entity new, blasts and immature mature basophils with metachromasia, blasts are negative for MPO SBB, no expression of strong CD117 to exclude mast cell leukemia. ML with maturation greater than 3% blast with MPO, maturing cells are of granulocytic lineage are greater than 10% of nucleated mono cells, monocyte lineage is less than 20%, expression of two or more myeloid associated antigens. Without maturation, again greater than 3% MPO positive blast, maturing, when without maturation means less than 10% maturing granulocytes, expression of myeloid precursors. And then, so you see there's some change, the categorization has been changed, the blast percentages have been changed, so you'll have to go through this. Fine. And always read the footnotes. Then myeloid neoplasms with germline mutation, we all know SEPA mutations. So, then myeloid neoplasm with predisposition and pre-existing platelet. So you see the headings have changed. Myeloid neoplasm with germline predisposition without a pre-existing platelet disorder or organ dysfunction. This entire word sentence was not there. It was just predisposition of germline. Now they have divided it on basis of the platelet disorder. Why? Because clinically they are seeing with germline mutated AMLs, you're getting a lot of platelet disturbance on CBCs. Like it's like a catching factor for a clinician that there might be a germline mutation. So you will get thrombocytopenias in a lot of platelet disorder associated AMLs like Ranax1, ETV6, PLP variant, ANKDR. All these have thrombocytopenias. Fine. And then there is myeloid neoplasm with germline predisposition, potential organ dysfunction like GATA2 mutation associated with bone marrow failure syndrome like Schwammen-Diamond, Fanconi's anemia, rasopathies. You have to go through it and read it. Biallelic BLM PLP variant Bloom syndrome means somewhere where there is a platelet dysfunction or a count dysfunction. And thrombocytopenia, bone marrow failure syndromes. You must have read bone marrow failure syndromes might progress to MDS AML. So now they have put that in the classification. So these terminologies have changed. Instead of calling it just predisposition of germline mutation, you have to divide it into with organ dysfunction, with platelet dysfunction, and with both organ and platelet dysfunction. Fine. So you have to read and learn. So myeloid neoplasm, MDS, MP, and AML post-cytotoxic therapy are now MNPCT, requiring proper diagnostic workup. Exposure to PARP1 inhibitors added as a qualifying criteria, and the diagnostic framework for myeloid neoplasms associated with germline predisposition is restructured along a scalable model, which I showed you right now, and can accommodate future refinement and discoveries. So thank you so much. It's another 9-10 minute lecture, and I'll come back hopefully soon with the last two parts of the paper. Thank you.